Welcome everyone to today's program. I'm Molly Gamble with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Mirza Baig is a technology strategist with more than 18 years of experience in various roles at the White House, Infosys, and Cisco. He has successfully founded 3 startups. He's also received the Distinguished Service Medal and Outstanding Leadership Award while at the White House and Best Department Management Award at Infosys. Currently, he is serving as the CTO in hospital medicine for MCare, specializing in referral management. Dr. Francisco Loya is CEO of MCare Hospital Medicine. In addition to his MCare duties, Dr. Loya serves on several committees for the Society of Hospital Medicine, including the Practice Administrators Committee, the Hospital Quality and Patient Safety Committee, and the Information Technology Committee. As a physician, Dr. Loya specializes in internal medicine. After earning his master's degree, Dr. Loya created the technology he named CMORX, which is now offered exclusively by MCare. It is now my pleasure to turn the floor over to Mirza to begin today's presentation.
Thank you very much, Molly. My name is Mirza. Good afternoon, everybody. Hope everybody's doing okay. So we have a very exciting and unique presentation, I think, for you all in the next 57 minutes or so. And what we want to do is basically cover in today's session the opportunity cost around unmanaged referral process and what the best practices for managing direct admissions for healthcare and also referrals from provider to provider, specifically physicians and other entities as they are interfacing with those physicians. And of course, delve deeper into 2 specific tools that we think will have a great impact on the overall referral preference, as well as enhance the patient satisfaction levels as well. Next slide, please. So when we look at physician engagement overall, NIH sort of defines that or categorizes those pieces of engagement in 3 different categories of integration. One is non-economic, which essentially deals with referral services, physician liaisons, which a lot of the hospitals have employ, some of the platforms, the technology platforms that exist, the marketing efforts that you as a clinician or a hospitalist or even as a hospital administrator have, et cetera. That's one part of integration, non-economic. The second part is economic. Obviously, bundle payments, value-based purchasing, ACOs, et cetera, would fall into the economic side. And clinical, which is on coordination of patient care. And that's the area that we're going to focus in on vis-a-vis referral management. And if you sort of look at it at a high level, what you can do is clearly see synergy between these 3 types of integration and engagement with CMS's triple aim, which is better health care, and at a lower cost. So if you were to say better health, you start looking at the clinical aspect. You look at lower cost, you look at the economic aspect, and you start looking at better health care, the actual delivery of health care. You start looking at the non-economic parts of it. Obviously, there's a lot of overlap between the 3, but you can still see at a broader level what NIH has categorized vis-a-vis engagement and what CMS's triple aim goals are. And I'll be referring back to those triple aims consistently throughout the presentation. So just keep that in mind as we sort of go through this particular presentation. Next slide, please. So if you look at referrals, again at a high level, the 2 that I'm going to focus on, we're going to focus in on is the many-to-one and the many-to-many. The many-to-one essentially has a entity or a facility as the main central cog, right? Like for instance, a hospital where physicians and specialists and SNFs and urgent cares and nursing homes are essentially sending in referrals into a hospital. And then you have the many-to-many, which is on the outpatient side, which is outside physicians to specialists, SNFs to rehabs, et cetera, right? Those are the many-to-many. And throughout this presentation, again, we're going to talk about the various problems associated with that, but around these two models. The third one, which is not represented here, but as you can imagine, is on the self-referral side, which is a large market. There are a variety of different platforms for it, but that's outside the scope of this particular webinar. Next one. So as you start at the top of the hour and go down, you start looking at the impact of unmanaged referral process. The 2, 3 clear ones that stand out obviously are the continuity of care, the delayed care, which obviously has an adverse impact on overall health and health care. And you look at the medical errors that are associated with where patient information is not being appropriately exchanged, the fact that redundant tests are being ordered. All of this essentially leads into wasted resources, a lower patient satisfaction, and which in essence leads to a lower rate of referrals and admissions. Obviously, people will send patients to other care providers that they have confidence in that they will take care of the patient. And if all of those aspects are there or not there, it will obviously have a adverse effect on the rate of referrals. Next. My boss at the White House, Tim Campen, who was a special assistant to the president, when he first started, he mentioned that there were 3 most important aspects to the job, and then those were communication, communication, and communication, and that clearly applies in the healthcare field as well. The Joint Commission, the data suggests that poor communication contributes to nearly 70% of sentinel events and surpasses commonly identified issues such as patient assessment and procedure compliance. You all know this. How to make it happen is the question, right? Especially as the patient is transitioning from one provider to the next, either within your entity and obviously as they're going between different care providers and different entities. So it's a well-known issue, and there are a variety of different solutions that have been proposed, and we have a specific take on how to solve part of the problem around communication. It's part of your toolbox per se that we are going to talk about later on in the presentation. Okay.
I think this is Francisco Loya. I just wanted to add that the poor communication also extends to communication with what can be termed just-in-time information. Some information is communicated at the point of discussion, for example. However, it may not be written down by the receiving physician. But on top of this is also just the number of distractions that the receiving physician may be experiencing during the handoff. Such as if the physician is sitting on the ward, nurses, case managers, patient's family members may be trying to gather her attention. She may have other information in front of her while she's receiving the information from the referring physician. In those cases, information tends to be lost, even though it was initially received.
Right. Good point, Dr. Loya. So and when you look at direct admissions versus ED admissions, almost every single hospital, every single facility essentially is dealing with how to reduce overcrowding in the emergency department. You have roughly about 140 million plus visits to the ED. About 12%, about 15 million or so actually essentially get admitted or get transferred onto the floor. And the national average wait time is about 24 minutes or so. So the problem is quite wide, but specific to direct admission, you have that 15 million people that are being admitted into hospital. Keep that in mind as we sort of go into the next slide here, which is where you obviously, if you're doing a direct admissions, the numbers for 2012, 2013 are roughly around 40 million a year. And if you look at that $15 million component, 15 million patient component, that's a significant portion of admissions that are being done into a hospital. More than 33% that are actually going into that are actually coming in from the ED. So if you have the opportunity to reduce that number from the ED into the floor versus do a direct admission and not have them go to the ED, obviously that will enhance patient experience, and the fact that they're waiting 24 minutes to be seen on an average, that will also obviously impact the quality and the continuity of care as well. Next slide. Gallup did a study on physician referrals and basically came out with a statement that said that engaged physicians are that are engaged vis-a-vis the hospital gave an average of 3% more outpatient referrals and 51% more inpatient referrals than those who were not engaged. And the engaged part of it, if you go to the next slide, is essentially going back of how that engagement in the first couple of slides that we talked about really is, and who they consider to be a colleague, which we'll come to in a minute or so. If you look at the market, for instance, around referrals, you have about 462 million primary care visits in the outpatient setting, and you have 516 million or so specialist visits, and the number that overlaps the two, whereby there is actually a referral being done, is 161 million, which is huge, right? And obviously, that's just referrals. That could be simply, hey, call this particular doctor or see this particular doctor. That may or may not include any paper exchange of information, and certainly a very small percentage of that is electronic. So you can see the opportunity as you look at it from a pure outpatient setting. Next slide. So the key here is to obviously make sure that you're exchanging patient information. You start with that 161 million referrals that are done in the outpatient setting. And you want to obviously expand the fact that there are more referrals being done between care providers, and you're exchanging information securely and at an appropriate time, as Dr. Loya mentioned earlier, and also that the right amount of information is being transferred, right? And in terms of actual referral patterns, you start looking at who are they referring to. They're referring to their colleagues mostly. And how do you define a colleague? Colleague is somebody who they have integrated with either on the economic side, the non-economic side, or on the clinical side. And the key point of this particular aspect, this particular study that was done, is talking about ease of communication. You're going to refer to patients, you're going to refer to your colleagues that are easy to deal with, right? And the underlying platform could be the same, but that does not necessarily have to be. But in this particular case, they say they share my medical record system. Why? Because it's easy to take the data from point A and then transfer it over and communicate that with my colleagues. So you start seeing some patterns in terms of what the behavior is vis-a-vis referrals between care providers. Obviously, if you were to remove that platform perspective, because uniformity in the platform in the record is essentially the same medical record system, is not possible, as we all know. There's healthy competition in the market. If you were to remove that, then you're essentially looking at that ease of communication piece. So how do you enable communication across a diverse platform and essentially make that a non sort of like an agnostic as far as the decision to refer to your colleague or not. Next slide. And you start looking at, so we talked about the scope of the overall referrals. I mentioned that 161 million are actually referred from in an outpatient setting. Obviously, out of the 40 million overall admissions, some of them are obviously referred electronically as well. We don't have specific numbers on that, as far as I can tell. But you can imagine that the numbers are much lower than the 16% in the inpatient setting alone. So, but roughly let's go with the 16% figure that are completed electronically. Even so, 3 out of 10 tests are reordered, which is a humongous opportunity as far as lowering cost, part of the triple aim of CMS, for instance. 20% of patients just referred, just don't show up. Where did they go? Did they even go? Who did they go to? Is there a loop back to the referring physician? Those are unanswered. And then once the patient actually walks into a hospital, for instance, only 3 to 20% of the discharges are actually communicated between a hospital and a primary care physician. And that number is roughly the same when from between a hospital and a primary care physician. So the discharge piece obviously is quite a big opportunity as well to make sure there's continuity of care as the patient is being discharged from the hospital into the outside world. So that represents a huge opportunity. Next slide.
I think one other opportunity that the technology and that the processes address is Mirza mentioned the 20% of patients who didn't show up. There's a large percentage of patients who, when they do show up, do not show up in a timely manner. That is, they could show up at the end of the business day when support staff are getting ready to leave, even though that they were evaluated by the primary physician hours earlier. And so getting them physically to the hospital also is a bottleneck that needs to be addressed. Absolutely.
If you look at the emerging world with bundled payment, et cetera, this becomes even more important vis-a-vis readmissions and the fact that communication actually is critical to making sure the transition of care. So, for instance, if you look at the stats from 2011, 2012, 50%, more than half of the patients that were readmitted never had a follow-up visit with the primary care physician. Right? That's something that that can be fixed, right, with a little bit of effort. You have the efficacy of a follow-up visit with the primary care physician are clearly there, whereby only 3% actually get readmitted if they had a timely follow-up versus people who did not, right? They were 10 times more likely to be admitted. And then, of course, even when the follow-up visits are done, it's not just about making an appointment, but it's also about exchanging of information, providing the relevant information back to the primary care physician or the care provider to make sure that there's continuity of care there as the patient is being discharged. And of course, all of this translates into huge numbers of dollars. In this particular case, the medication errors themselves are about $3.5 billion, which translates into obviously several percentage points in the overall annual cost of health care in America. Next slide, please. So, according to Commonwealth Fund, who did a case study, integrating hospital and outpatient care is key to reducing readmissions, right? That is pretty obvious, but given the current state and where we're going from a bundle payment perspective, that becomes even more critical from a monetary perspective. Next slide. So, what do the solutions start looking like? So up to now, we've talked about the various problems, talked about the various stats associated, the metrics related that sort of depict the problem. So what are the solutions? So the next several slides, we're going to focus in on two specific types of solutions. One is that many-to-many that I talked about, and the other one is many-to-one. We'll look at many-to-many first and say what is a possible solution to this particular effort and how we have implemented it internally and within the overall Envision family. So from a many-to-many perspective, the key is to basically look at how do you enhance communication between physicians, care providers, generally speaking. How do you create that stickiness in your overall referral network? Because obviously you are all in business and you want to make sure that you continue to get that referrals from your sources. And the fact that not only do you create a stickiness in the existing referral network, but you also expand the referral footprint so you get more across the community rather than just rely on a few, right? So talk about that many-to-many in the next slide. So the solution for many-to-many we have is Karma, right? Consultant Referral Management app. With Karma, what you can do is basically create a trusted network of providers, right? This is your engagement integration on the economic on the clinical and on the non-economic side, right? And you can also have the opportunity to connect with providers within and outside of the network. So even if they're not part of your network, you can still reach out and leverage the platform to be able to do that. And you can also obviously bring in the patient into the loop as you're providing continuity of care in terms of, hey, you have an appointment coming up, et cetera, those kind of things, and of course do it in a secure and in a timely manner. All of this obviously will help you analyze and get metrics on who are your referral sources, what does your network look like overall, are you getting notified at the right time whenever there is a referral, and are you acting on it? Remember that ease of communication that referees actually are very keen on. This will help you respond in a timely manner. You can delegate that to your staff as you sort of build and scale your that capability, and of course you can do it from any device. Next slide. The two use cases that I'm going to talk about of how this is implemented, one of them is with Evolution Health. Evolution Health, as some of you may know, involves population health management. Basically, from the point of discharge, the goal is to obviously avoid readmission, right, and take specific care of the patient. From the time of discharge, the patient is going through a variety of different care providers, right? There's an eval process, there's a criteria, there's a home health agency involved, et cetera, et cetera. All of those things are part of your overall population health management. So variety of different users, variety of different stakeholders, majority of which is planned because, again, your goal is to avoid readmission, possibly 30 days, 60 days, 90 days, depending on the contractual obligation. And you can leverage Karma to be able to do that and do it in a secure and in a timely manner to communicate between the care providers as the patient has been discharged and is at home, for instance. The next use case, which is in the next slide, is with AMR. AMR, as you know, has one of the largest, is actually a dominant player in the health mobile transport market. AMR leverages Karma to basically connect with hospice in a hospice setting, again, after discharge, to make sure that the patient is well taken care of within the hospice confines and timely and TLC is provided for the patient, right? Both from a mobile paramedic sentinel perspective and also from a hospice perspective as well, because it's a combined approach as they take care of the particular patient. And the patient is engaged directly, so instead of calling 911, for instance, for something that does not necessarily involve 911, they can leverage a smartphone and a device to be able to do that and communicate directly with a command center on either side, the hospice side or the AMR side, to be able to leverage the care that they need for their loved one or for the patient directly themselves. So both of those use cases are, again, around population health. One is on the planned side, which was Evolution Health. The other one is more on the unplanned side, although you can still schedule some planned stuff in there as well, just to give you an idea. So those are the two aspects around the many-to-many that I talked about earlier. If you go to the next slide, we'll sort of transition into the many-to-one, whereby physicians are sending into a hospital from a direct admission perspective, and you obviously, the goals are to reduce the ED wait times and overcrowding, enhance the patient satisfaction, and of course improve quality and continuity of care as well. So that's the overall, that's what you're looking at from a solution perspective. The solution that we have is referred to as DASH. If you go to the next slide, please, which is a direct admit system for hospitals. And it's quite simple, actually. What you have is basically on the referring medical side, you have a primary care physician, clinic, a freestanding or urgent care, etc. Basically, having made a decision to do a direct admit, basically pulls up the form, fills out the information that's needed as per the hospital protocol, and sends it over both to the admitting physician and to the house supervisor, who then review the information, make sure that it's clinically appropriate for the patient to be admitted, have a doc-to-doc, which is, again, enhanced, part of the Joint Commission's recommendation. And then basically, and then once that decision has been made, you go ahead and send a boarding pass over to the patient under the referring facility, basically similar to your airline boarding pass, which basically tells you where to go, which gate to enter through, what your bed number is, or any other details that the hospital may want to include as part of that particular boarding pass. So that can be sent directly to the patient if they have a smartphone, or they can it can be printed out and handed over by the referring facility as they're walking out towards the hospital. Next slide, please. One of the key things that we have, which is quite loved by our referrers, is that button that you see, the easy button. Similar to the stable button, except this is actually this it's clickable. It's you plug it into your USB at your clinic's desktop or laptop, and whenever they need an admission, it's private label for that particular hospital. You click on it, the website pops up, you log in, you fill out the form that you see there, and obviously that form is quite flexible and agile, and you go ahead and hit the admit button, and they start reviewing it, and then the various the notifications start flowing in the next slide, for instance. So you get the boarding pass on the left-hand side on your smartphone. You get the alert on the admitting physician or the house supervisor saying, hey, there is a transaction waiting for you to review and possibly take action on. And all the information that was previously entered by the referring facility is now part of your, is now visible to you as you're reviewing that and either saying yes or no to that particular patient. Next slide. Sorry, Dr. Loya.
Yeah, I wanted to highlight that what you just saw is a very simple process where lots of people were communicated simultaneously within the hospital, which improves the patient flow from the primary care office into the hospital. What you created is a very quick path of least resistance. It's easy now for the primary care physician's office to direct the patient and to get the patient admitted into the facility with all the key stakeholders being notified. In addition, from the hospitalist point of view, the accepting physician receives the information that is required and can refer back to that information as needed when the patient comes. And so that is it's a very simple diagram. However, the results are rather impressive, and how patients accept the referral and the time that they take to get to the facility all is compressed and is streamlined rather significantly.
Absolutely. So, for instance, one of the metrics that we have is one of the things we measure is a click to bed arrival time, right? And the numbers have been, as a hospital and the physicians, the community physicians continue to use it, that number keeps dropping down. So right now it's at about a little less than 3 hours from click to bed arrival. When we first get started at any hospital, for instance, that number generally is around 5 or 6 hours. So think about this, right? So the request is made, the bed's been assigned, essentially reserved, within that first 30 minutes or 35 minutes, both in terms of acceptances by the physician and the bed being assigned, and then you're waiting for the patient to arrive. So you now have access to a lot of data, and you can look at efficiencies from a hospital perspective that can say, you know what, we need to look at that specific bottleneck that exists to bring that down. But at the end of the day, once the reservation is made, essentially, once the acceptances are done, the patient's walking in within a 3-hour period, and the no-show rate for those patients is less than 1%, 0.78% to be exact, which is humongous, right? That's less than, for instance, what the no-show rate is at airlines, for instance, right? So once you have it confirmed, you're pretty much assured that the patient is going to walk in within that average time of 3 hours. So, again, you are trying to build a network of your referral network, create stickiness, expand that referral footprint as well, and this could be a great tool in doing just that. Next slide, please. The impact is significant. Again, I'll keep on going back to that particular quote that you saw, which was on ease of communication being cited as one of the main reasons in terms of referring to a colleague, right? And you can tell that if you have a system that is seamless, that as Dr. Lohr mentioned, path of least resistance with the appropriate amount of information and the doc-to-doc that is occurring, you now can build that loyalty and stickiness and convert those splitters that potentially were sending it to someone else. And you can see the results across a variety of different referring medical facilities, lower acuity hospitals, for instance, a freestanding ER, urgent care, et cetera, et cetera. You can start seeing that the referral patterns within several months are changing significantly and adding to your overall value proposition. Next slide, please. So I want to take the next 4 slides to sort of look at a specific case study of how this will work. We have a hospital in the South. Next slide, please. So we have a hospital in the South. It's a rural hospital, but it's close to a major metro area. So it's sort of transforming from a rural to a suburban setting. 360 beds, has about 9 acute care hospitals. The competition is fairly stiff, given that generally speaking, the next hospital is literally 5 minutes away, which in an urban setting could be the next block, for instance. So even though it says 6 miles, it's not that much because people are, it's right down the street, which is 5 minutes away. So you still have competition, and you have a variety of different hospitals within that radius where patients, providers, et cetera, referees have a choice in terms of who they want to send it to. Fairly solid occupancy rate, and average 60 direct admit patients per month, I should add, in 2013. Of course, the desired outcome was to build loyalty among high-volume referrers, and also to streamline the admission process and make sure that they garner the efficiencies or realize the efficiencies by leveraging technology. Next slide. So when we first started, the response times, both from the overall process, I mentioned the click-to-bed arrival time, sometimes reached over 10 hours. And this was essentially emblematic of existing process. What we're doing is basically bolting on the technology component to their existing business process, and it was very, very efficient. It was not measured before because there was no tool to measure it, but now it was measurable. And of course now, and then there are a variety of different bottlenecks as well in terms of bed availability and not, even though the overall percentage, their occupancy rate was still not closer to 90 or 95%, for instance. Next slide. And as you can tell, if you look at that green line there, the overall number of direct admissions as they got more efficient, the fact that they created this direct admit unit, which was basically a pool of beds, under the observation sort of status, that whereby if they had a referred direct admission and the doctor and the physician has done a doc-to-doc, they basically bring in that patient, even though they may not have beds overall on the floor, they at least get them into the observation, that direct admit unit that they refer to. So that way they were basically making sure that the people who were sending to them, referring to them, were getting a yes, generally speaking, and of course that the wait time and the time to actually provide continuity of care was much less, which increased the satisfaction. So you see that in numbers as well, right? So when we first started and as we started growing in 2013 all the way up to 2015, We're now at about 148 direct admissions per month versus 60, which is what we started with as a baseline. So you can tell that by making it easier, by exchanging information in a much more timely and appropriate manner, you are able to not only create stickiness with your referrers, you're also able to increase the patient stat, and you saw the click-to-arrival time, which was hovering around 9 hours, down to about 3 hours in 2015, which is sort of typical of the hospitals that we go into, because it does take some time to generate that efficiency, to streamline that process of direct admission, because the number of stakeholders are so large. Some of them are captive, meaning they're part of your hospital ecosystem, and some of them are on the outside who may or may not necessarily be as technology savvy as your internal folks. Right? Next slide. So the referrals, so the results are pretty significant, right? They increase their overall referrals by 27%, which is huge. Basically, again, building loyalty. The number of phone calls were reduced by 90%. For each admission, they had about 11 phone calls, and they were able to bring it down to closer to 9.8, 9.7. The time that it took from a referring physician perspective was less than 3 minutes in order to actually send over the information, and they can obviously attach the requisite form, versus earlier that there was mostly phone and fax, and some of that information was not even transferred. And now you actually have metrics, right? Who's sending to whom, what the response time is, what's the admitting physician response time, what is the house supervisor response times. So you can actually create, you make this as part of your business development plan in order to go out and expand that referral footprint. So this, again, it's part of your overall toolbox to be able to generate, and build that stickiness. Next slide. So this sort of brings it to the conclusion in terms of the presentation. We covered obviously the types of referrals, the impact of unmanaged referral processes, the various problems, and of course the solutions vis-a-vis 2 specific technology solutions, and then the case study. What I'll do is I'll pause here. Dr. Loya, if you wanted to add something, if not, then we can go directly to the Q&A.
No, not at this time. I think we can go directly to the Q&A.
Great. Well, thank you, Mirza and Dr. Loya. It was a great presentation, great overview. So we do have some questions rolling in, and this will start the Q&A portion of the program. So as you can submit questions in the control panel there, in the space label, enter question for staff and clicking send, and the presenters will attempt to answer as many questions as they can during the time we have. If we do run out of time, they'll be following up on questions they don't have the opportunity to address. So one of the first questions here is, how can my hospital take advantage of this program?
So it's quite simple, actually. If you go to if you go to the next slide, actually there's a URL there for mcare.com/. There's a contact us form as well, and you can directly reach out to us. There's a phone number there as well on that particular URL that you can leverage to contact us, and we'll go from there.
Okay.
We should also state that the technology, when it sits in the hospital, in the physician's office, it's very, very simple install process. They basically it's plug and play. There's minimal training, and so it can get up and running very quickly.
Absolutely.
Okay, great.
It's a software as a service, so it's everything's web-based. There's nothing to install per se in your data center or in your office space. It's just a matter of just having a browser and a solid internet connection.
Okay. So I think that answers the next question that came in, was, is there any software to install or customize?
Nope.
Okay. All right, and the third question here, what sort of support is available to help engage physicians who don't work for the hospital?
I'm sorry, repeat the question again?
Sure. What sort of support is available to help engage physicians who don't work for the hospital?
So we have a variety of different aspects, right, in terms of the actual business model of driving user adoption. It depends on what you exactly want, right? If the idea is to expand your referral footprint, we outside in an outpatient setting, obviously, they're in one of the business model or packages that we have something called the adoption manager that is deployed to drive adoption and also to generate not generate but to increase your referral footprint. So it depends on how you define engagement and how you want to approach it. But generally speaking, we have specific we have several models that one can leverage.
Okay. Another question here referred to slide 17. What is stickiness that you refer to?
Well, stickiness is essentially how you want to generate repeat business, right? How do you maintain that loyalty from that person, from that entity, as you continue to engage in business dealings, right, with that person? So that's essentially stickiness. So basically capture hopefully capture all of the referrals from that particular clinic or physician into your entity. That's how that's what I mean by stickiness.
Great. And then the next question here is, can Karma and Dash tie into regional HIEs?
It depends. Obviously, regional HIEs, like I'm assuming that's state-based HIEs, and as and all the HIEs that I'm regional or state-based HIEs that I'm aware of, have a HL7 interface and basically follow the standard protocol, right? And if that's the case, the answer is yes. But if there's a regional HIE that does not follow generally the standard protocol, for instance, one of the new emerging technologies is the direct project, right? Direct messaging, for instance. That can be done, but that will take a little bit of time. But generally speaking, I don't think any, I'm not aware of any regional HIEs that are leveraging the newer technologies. And so the answer is yes, a cautious yes.
Okay, wonderful. And then Mirza, this one is referring to the case study that you kind of ended the presentation with. In that case study, was there any impact on the ED admissions?
That's a good question. So it's hard to sort of identify the impact on ED numbers, right? If there is an increase, so let's the assumption is that if Dash wasn't there, would the numbers in ED go up or down, right? So that's like and that's really tough to sort of answer. To say, yeah, because of Dash, the numbers actually the wait time went decrease, and the volumes increased, and even then the wait times decreased, because it's part of an ongoing effort from every hospital to reduce ED crowding, right? Overcrowding. So I think it's part of the overall solution toolbox. It's not a direct causal relationship that you have Dash and as such your ED crowding has decreased and even though the volumes may have increased. So I'm sort of hesitant to draw a direct relationship between the two, although, again, it's part of the overall strategy, not the only solution that you're deploying.
Okay. Okay, another question here. Has this software been used at SNFs, ALFs, and urgent care centers? As a primary care physician, my patients migrate based on their medical problems.
Absolutely, yeah. Majority of our installs are at primary care physicians, because that's a large number of them out there. But some of our more fervent users are urgent cares, some SNFs, and certainly some freestanding ERs, right? Because of the type of patients that they're seeing, they tend to employ it more than a regular primary care physician who may or may not be sending one or two direct admissions on a monthly basis, right, depending on the practice. So, more fervent ones are certainly urgent cares and SNFs and freestandings.
Okay. And then does DASH facilitate communication with referral sources?
Does DASH communicate? Yeah, absolutely.
I'm sorry, facilitate, yeah.
Yeah, so one of the key things, and I don't think I touched upon this, was on the discharge piece, which is once the patient is discharged. So we talked about two different tools here. One was Karma, the other one was DASH. Karma is purely after discharge, right? In sort of like an outpatient setting, either with hospice or home health or other use cases. With DASH, you also have the ability to be able to send out the communication back to the referring physician at time of discharge to say, hey, listen, your patient's getting discharged. You want to follow up with that particular patient. So they're not going to another tool. They're actually just pulling up DASH again because they got that notification. They're saying, okay, the patient that I sent in is now being discharged. I know the history. The case manager has now attached the discharge notes, so I can review that as well as I schedule the next appointment for this particular patient, so I can avoid I can provide better health care to that particular patient. So it's sort of DASH does a specific piece of it, and Karma does the other elongated piece across a number of days.
Okay. Well, thanks, Mirza. So thank you to Mirza and Dr. Loya. It was a really wonderful presentation, a great overview, lots of information, covered a ton of ground. So we thank you again, and we look forward to having you join us for future webinars. And thank you for all the attendees today who listened in. We really appreciate your time. This concludes today's program. We hope you have a wonderful afternoon. Thanks so much.
Thank you.
Thank you.